Good afternoon, everybody. I hope all are doing well, and I will welcome all of you for joining the academic hour brought to you by the GMOA Academic Subcommittee. So today we will be discussing, as you all are aware, we will be discussing of a very, very important topic. So it's not only for Sri Lanka, it's in relation with global health. It is all about antimicrobial resistance and all about antibiotic prescriptions, which we do daily on a daily basis in our clinical practice. So today we have with us a very young and energetic consultant. Let me give a small introduction about our resource person today. He is Dr. Lakmal Fonseka, who is a consultant physician at the Teaching Hospital Karapitiya and a senior lecturer at the Faculty of Medicine, University of Ruhuna. He obtained his MD in General Medicine in 2017 and received the gold medal for best performance that year. He obtained a PhD at the University of Oxford in infectious diseases and immunology. He completed his overseas training at the Oxford University Hospitals in 2022 in internal medicine and infectious diseases. He also received the honorary fellowship awarded by the Royal College of Physicians in 2024. Other than this, he received many awards for his research publications. Dr. Lakmal's main interest is to improve understanding of dengue, leptospirosis, and to fight antimicrobial resistance in Sri Lanka. Dr. Lakmal, it's over to you to enlighten our learned audience. Thank you.
Good afternoon, everyone. Thank you, Rajiv, for that introduction, and I hope all of you are well. Today, we are going to talk about an important topic on how to treat the common infections that you see in your general practice. It can be at primary care level or it can be at outpatient departments in the hospital. So there is one of the most important areas that would be important for our day-to-day practice. So we'll start with the case. So there's a 55-year-old doctor who admitted to the hospital with a history of fever and signs of a pneumonia. We have started on ceftriaxone and clarithromycin, and the patient deteriorated even after 6 hours and was started on meropenem and vancomycin. Mind you, this is the best antibiotic regime that we have in the hospital. Her oxygen requirement increased and needed intubation and ventilation, and inotrope requirement increased, and subsequently, after 72 hours of admission, she sadly succumbed. So this is a real case, ladies and gentlemen. It can happen to any of us. And later, the blood culture grew MRSA, which is a methicillin-resistant Staph aureus. This is a resistant variant of the usual Staph aureus that we see in our day-to-day practice. So we have some questions to ask. Why did she die? And she was started on the maximum escalation of antibiotics, meropenem and vancomycin, soon after admission and still died. And how did she get MRSA? So to answer these questions, so why did she die? I would say because of a severe pneumonia. She was started on maximum antibiotic cover with meropenem and vancomycin, but still died. What's the reason for that? It's because when you compare the usual Staph aureus, methicillin-sensitive Staph aureus, compared with the methicillin-resistant Staph aureus, MRSA has a higher mortality to begin with. So whatever you do, if there's a resistant organism causing an infection, you are faced with higher mortality, higher morbidity, and a longer hospital stay. An antibiotic also needs time to act. And also, how did she get MRSA? That's an important question. So being healthcare workers, we are at high risk of acquiring these resistant organisms when we are doing our hospital practice. We can acquire that through patients, and also we can acquire that through the contact surfaces of the hospitals as well. Case number 2. This is a patient that I saw recently, a 15-year-old girl present to the outpatient department with a urine culture report showing ESBL, extended spectrum beta-lactamase producing E. coli. So this is a resistant E. coli, sensitive only to meropenem. And I did not have any other choices of antibiotics to give, sadly. She's healthy and has not got admitted to the hospital previously and has no comorbidities. So why did she, being a 15-year-old previously healthy, why did she get an ESBL infection? And how did she get an ESBL infection? So we have to understand these questions. So why did she get it? I'm unable to answer that. It's unclear why she got it, even having apparently normal immune system. How did she get that is an important question to ask. So one reason is, if somebody has gotten repeated antibiotics for like milder infections, you can subsequently end up with having a very resistant kind of an infection, with a resistant bacteria. So let me elaborate you on that. So these, if you look at number 1, this shows the bacteria which is inside your gut. Imagine this, there is blue bacteria and orange bacteria. And when we give antibiotics anyway, when we give it for a pneumonia, whatever you do, you lose some of your commensals or the healthy gut bacteria that you are having. So in number 2, we have seen that a patient getting antibiotic and the blue bacteria dies, and we are left out with some resistant bacteria. Imagine if we do this repeatedly on a person, then we are always killing these nice bacteria that they control the gut microbiome, and we are left with this resistant bacteria. And one day we will get infections only with the resistant bacteria, because that is the normal gut microbiome that we are having. Antibiotics are very different from the usual drugs that we use. Imagine metformin or antihypertensive. You prescribe for a patient, and that patient will get the benefit of that medication. But if you prescribe an antibiotic, it has an individual impact plus a community impact. Because it will cure the infection on that patient, but as if we are prescribing antibiotics repeatedly, we will be inducing antibiotic resistance in the community as well. So this is, compared to the other drugs, this is a drug that we have to use very carefully in our day-to-day practice. So this is how the antibiotic resistance spreads. I think we have not heard that this is spreading before, but imagine this person whose name is Kamal admit to the hospital and get some antibiotics for his illness. Imagine he got like ceftriaxone during the illness. So even invariably his gut microbiome will have lost lot of bacteria which is sensitive to ceftriaxone, and we will be left with organisms which are resistant to ceftriaxone in his gut. And he goes to the community and he can spread these bacteria to his friends in the community. He goes home and he can spread these bacteria to his family members as well. So the cycle goes on. And as healthcare workers, I think we might be inoculated with this resistant bacteria as well. So it's important to have good hand washing techniques and be aware about infection control to prevent spread of this bacteria from us to the society and also to our family. Another case, a young patient who is having a Guillain-Barré syndrome admits to the hospital and dies with a ventilator-associated pneumonia. The patient did not admit due to an infection, but still has died with an infection, with a very resistant infection in the ICU. This is what an ICU MO has told me at that time. It is very difficult not to get VAP while in the ICU. We are helpless and sometimes feel pointless when patients die due to VAP. With all our efforts, you don't need to get admitted to the ICU because of this. So that's the advice that the ICU MO has given me at that time. So ladies and gentlemen, antimicrobial resistance is one of the most important topics in the current date. It is one of the major public health threats in the world, coined by the WHO. So in 2050, as you can see from the graph, the current AMR rate stands at 700,000 in 2019, and in 2050 it's going to be a massive number, reaching 10 million. It's going to overtake the number of cancer deaths as well. So look at these large pyramids. So these pyramids show the exponential number of cases, people dying with AMR. So in 2050, Asia and Africa will be having equally 4 million deaths due to antimicrobial resistance. And we are in the southern part of Asia, and we'll be facing the same problem as well. So, ladies and gentlemen, think about your future, think about your loved ones. Do we prefer to live in a world where bacteria are resistant to antibiotics? Aren't we having a moral obligation to retain the effectiveness of antibiotics for our future generation? Time to think about it. So basics of antibiotic prescription in your common infections, basically in your primary care level and also in the OPD level. We will be seeing 90 to 95% of the time, we will be seeing viral infections. So we have to ask 3 questions. Is it a viral or bacterial infection? Second, does it need antibiotics or not? And what is the appropriate antibiotics? And let's go through that one by one. So what is the basic of antibiotic prescription? No antibiotics for viral infections. Ladies and gentlemen, we don't need to give any antibiotic if you diagnose a viral infection. Except for influenza, we don't have any antibiotics for that. So all the infections, we don't need to give antibiotic, which is act against the bacteria. Use access group of antibiotics. I believe many of you might have not heard of it, but I'll let you know what it is. An antibiotic courses, the shorter the better. Give 3 to 5 days of antibiotics compared to 7 days of antibiotics. And good patient education, and invite a review in 48 hours time. So this is proven wrong. Initially what we thought is you have to complete the course of antibiotics. So unless you complete it, there is evidence of resistance. But now it is proven wrong. The longer you give antibiotics, the more that you are inducing resistance. I repeat again, the longer you give antibiotics, that we are inducing resistance more and more. So that is the current understanding, which is completely different from what we knew before. So how to differentiate viral from bacterial infection? Viral infections often has a contact history. The family members or the friends in the workplace might be having similar symptoms. And also there can be features of upper respiratory infections to begin with, such as rhinorrhea. And usually the vital signs are usually normal. Your pulse rate, blood pressure, respiratory rate is usually normal. And when you auscultate the lungs, it will be mostly normal. And if you have a CRP in hand, it's usually less than 40. And when you examine, you won't find a focus of infection. But important viral infection for us to be aware in Sri Lanka is dengue fever. Often have a severe anorexia to begin with. And also perform tests to prove whether it is dengue or not, as we have a good test NS1 antigen now. And presence of influenza COVID, if it is positive, you know it's a viral infection, not a bacterial infection. So by looking at this, you can judge whether this is viral and bacterial infection, and you have to develop your clinical acumen to differentiate viral from bacterial infections. So viral versus bacterial, only bacterial infections require prescription of an antibiotic. And antibiotics does not improve or reduce the duration of viral infection. And prophylactic antibiotics are not indicated in viral infections to prevent a future infection with another bacteria. And we always come across this in our practice, SEMA. So all SEMA problems does not need antibiotics. So you have to dig deep into that. In our society, people call SEMA for sore throat, frontal headache, phlegm, cough, wheeze, ear fullness, ear pain, for anything can be SEMA. So please dig deep into it and find out whether there is an infection that needs antibiotic or not. And mostly you will be treated with antihistamines, nasal decongestants, nasal drops, inhalers can be used. So what antibiotics are preferred to be used in general practice? It can be as an outpatient department in the OPD in the hospital or in your general practice. Whoever it is, if it is a medical officer or a consultant, this applies to all the people. So ladies and gentlemen, this is the thing called AWARE classification, access, watch and reserve group of antibiotics. So the ones in blue, the access antibiotics, are the ones that we must use in your primary care level. So amoxicillin, ampicillin, cefalexin, clarithromycin, clindamycin, doxycycline, erythromycin, these are the ones that we must use in our general practice. Look at the watch and reserve group of antibiotics. I'll brief you what is this access group. So watch group antibiotics are the antibiotics that we must use in the hospital setting, in ward setting. So azithromycin, cefixime and ciprofloxacin, these antibiotics should be used in the hospital setting, but not as first line in your general practice. And look at the reserve group of antibiotics. This should be prescribed only with the authorization by a consultant microbiologist. Levofloxacin and moxifloxacin should be used after authorization of a consultant microbiologist, ladies and gentlemen. So what is this access group antibiotic and why WHO has divided into like 3 groups? So access group antibiotics are narrow spectrum antibiotics which has lower cost and great safety profile, and often recommended as first choice in treatment and has the best therapeutic value, and it has the minimum potential to develop or induce resistance. This is the important thing, ladies and gentlemen. If we give the watch group and the reserve group of antibiotics, if we use this commonly, we are inducing drug resistance in the individuals, in the society, and we will be leaving with a population which would be resistant to all the antibiotics which are in the watch group and reserve groups. Imagine amikacin, ceftriaxone, meropenem. If we use it more, you are inducing resistance. So access group antibiotics are the ones which should be used in the primary care level or outpatient setting, including hospital outpatient department. So ladies and gentlemen, I will send you the government circular on this, which is developed in 2024, and you can go through more higher detail on that. So let's go for a case. 32-year-old female with sore throat, painful swallowing, comes to your practice. Also complains of cough and afebrile, no tender cervical lymph nodes, no tonsillar exudates. So ladies and gentlemen, this is a diagnosis of pharyngitis, which we all come across. And what is the treatment that you would give for this patient? So the answer is paracetamol and no antibiotics for this patient. So I'll explain you why. So pharyngitis can be due to viral or bacterial organisms. So bacterial organisms, when it causes pharyngitis, they have a very severe presentation. They have high fever more than 38 degrees with tender cervical lymph nodes and pharyngeal exudates. You will see yellowish spots on the pharynx or the tonsils. So in those instances, you can give an antibiotic. In all the other instances, you can give supportive care and good education. We often think that our antibiotics are not working. I think it's because you are treating a viral infection. So if you are treating a viral infection, your antibiotics will not have any, it won't change the course of the illness. So believe in your antibiotic that we have. So causative organism is mostly viral, more than 80% is viral, and rest of the main bacteria which causes group A Streptococcus, which is very sensitive to penicillin. So we have this CentOS clinical scoring system. If the patients are having high fever, no cough, tender anterior cervical lymphadenitis, tonsillar or pharyngeal exudates, you can treat these patients with an antibiotic. So ladies and gentlemen, if you think of a viral infection, you just need symptomatic treatment. Paracetamol, antihistamines, salt water gargle, and steam inhalations, and education about the natural progression of the course. It will increase in the clinical nature will increase in 2 to 3 days and will wane off after 5 to 7 days, and after 7 days you will be fine. So that is the natural course, and it is bound to happen like that. So when should you give an antibiotic is severe presentation, fever, tender cervical lymph nodes, pharyngeal exudates. If you see those things, you can give an antibiotic. And what will you give? Amoxicillin, a good old friend, is fine for like 5 days of illness. So if you're allergic, then you can use the other options such as cefalexin and clarithromycin. So we move on to another case. So 30-year-old man with no significant past medical history ask you for a prescription for an antibiotic. This happens frequently to us. So he had fever initially and then settles and has all began after a runny nose. So he had a preceding viral sort of infection and then having all these symptoms thereafter. So on examination, she is well and not having any problems thereafter. Sorry. Give me just a second. So this is a case of bronchitis. Initial viral infection followed up with a troublesome cough, troublesome productive or non-productive cough. And when you examine the lungs, usually the lungs are clear, does not have any crepitations. We see this commonly in our general practice these days. And what we have to give is general symptomatic treatment. You can use some antihistamines, some inhalers also. Inhalers can contain steroids as well because there's a lot of inflammation going on. And you have to educate these patients on the natural course of this illness. So bronchitis is an acute onset troublesome cough. It's very troublesome cough lasting for more than 5 days. Can have scanty amount of sputum which does not indicate an infection. So yellow-green sputum can be there and caused by respiratory viruses. Mind you, ladies and gentlemen, it is not caused by a bacteria. How do you differentiate this with pneumonia that you usually see? So bronchitis is mild. Usually patient is relatively well other than the troublesome cough and does not have systemic signs of infection. And lungs are clear. You don't hear any crepitations. It is usually self-limiting, no antibiotic treatment is necessary, and you have to reassure that this is going to last for 2 to 3 weeks. Haven't we seen that in our practice these days? So the antibiotic treatment is not indicated, and treatment with symptomatic care. Paracetamol, you can give some NSAIDs as well if there's a lot of inflammation, and you can use inhaled steroids, antitussive agents, and lot of educations and reassurance that this is not a pneumonia is what is important. We go for another case. 25-year-old female admitted upper respiratory tract infection and now having a left side headache with facial pain and nasal congestion for 1 week duration. So it is clear that we are dealing with acute sinusitis. What is your preferred strategy of treatment? So prescribe medication for symptomatic relief, including antipyretic analgesics and nasal decongestants. I'll explain you why. So acute viral sinusitis is the most common thing that we see everyday practice. Nasal, it can start with a mild upper respiratory tract infection. There can be nasal drainage, congestion, unilateral facial or dental pain, facial fullness. Sometimes you might experience some tenderness over the sinuses, and usually lasts for 10 to 14 days, and it is self-limiting. Usually lasts for like 2 weeks. That's the natural course of the illness. When do you have to prescribe an antibiotic if you are suspecting sinusitis? So these are the indications that it is bacterial sinusitis. So if the symptoms are persisting more than 7 to 10 days without improvement, then you prescribe an antibiotic. Or if there's a significant worsening of symptoms after initial mild phase, you can prescribe an antibiotic. So ladies and gentlemen, these are the 2 instances that we have to give an antibiotic for this patient. So if it is a mild to moderate presentation, you don't need to give antibiotics less than 10 days and it is improving. Watchful waiting and reassurance, you can give antipyretic analgesics, antihistamines, you can give lot of steam inhalation, nasal irrigation, topical nasal glucocorticoids, you can use all these things. And if it is severe with the red flag signs mentioned here, systemic toxicity, persistent fever, periorbital redness and swelling, severe headache, if those are there, you can give amoxicillin and clarithromycin. Mostly it's coming from streptococcus pneumonia, and still these drugs works fine. But if you feel that somebody has given amoxicillin before and has not responded, or given clarithromycin before, then you can use a second line of co-amoxiclav. So you usually don't need an X-ray for all these patients. If it is less than 10 days, I usually do not ask for an X-ray. But if it is persistent symptoms, you can ask for an X-ray sinus view. Yeah, we move on to another case, which is very common these days. I am basically residing in Galle, so we had recent floods. So we see a lot of these cases recently. A 27-year-old male, watery diarrhea 15 times a day, cramping type abdominal pain, nausea for 2 days duration. He claims that he has taken street food. Maybe he might have come across with a flood recently as well. On examination, no signs of dehydration, and he's otherwise well. What is the management for this patient? Right. So the answer is advice on ORS, electrolyte replacement, and send home. So acute infectious gastroenteritis, we see this commonly. These days what I see is they are having more upper gastrointestinal symptoms to begin with. Lots of vomiting and dyspeptic symptoms rather than having diarrhea, and later they develop watery diarrhea. So we call it diarrhea if it is 3 or more unformed or liquid stools for 24 hours. And what is the causative organism? If it is watery diarrhea, clearly ask in your history whether there is blood or mucus. If it is not there, it's water. So if it is water, it's caused by viral infection. If there's bloody or blood and mucus diarrhea, you have to suspect bacterial infection. So usually you don't need to do any investigations at the primary care level. But if it is a person who is immunocompromised, on like chemotherapy or immunosuppressants, prednisolone or something like that, then you will have to refer this patient to a specialized care. Otherwise, you can treat these patients with education and lot of hydration. So the treatment, rehydration and electrolyte replacement is mainstay. You often see these patients very sick and dizzy. It's because of dehydration. And when you replenish that, they will be feeling better. And mild to moderate infections, you don't have to give any antibiotic. No antibiotic care in most cases. Mind you, this is the WHO terminology now. So what they have mentioned, no antibiotic. By not giving an antibiotic, it does not mean you are caring for the patient. You are doing the best thing for the patient by not giving an antibiotic, because you are not inducing any resistant bugs in the patient's body. So, and the indications for treat an antibiotic is acute bloody diarrhea and fever, persistent diarrhea not improving for like 7 days, severe symptoms with total incapacity of daily activities, and severely immunocompromised patients. So these are the instances that you have to prescribe an antibiotic. In many of us, even I was under the impression that the first line is like ciprofloxacin for an diarrhea. So I would say first line for an infectious diarrhea is no antibiotics, because what we see is mostly watery diarrheas which are virally nourishing. So if you want to give an antibiotic, if you think that is bacterial, clarithromycin and azithromycin are the choices that we can use. This is beyond our traditional understanding that ciprofloxacin works. Actually, ladies and gentlemen, ciprofloxacin is resistant in most of the cases because of the wide use. Because it's a cheaper drug, now we have used it a lot, and now it is resistant in most of the cases. And you will see that ciprofloxacin is not an access antibiotic. It's a watch group antibiotic. So another case, a person having a lower UTI, a cystitis or a urethritis. This patient, there's a urine sample was sent, shows E. coli, ESBL, resistant to comoxiclav, ceftriaxone, sensitive to cotrimoxazole, nitrofurantoin, gentamicin, and meropenem. So this patient, ladies and gentlemen, you can treat with a mild antibiotic that we are using, nitrofurantoin or cotrimoxazole. We have used these antibiotics for such a long time, but still is it effective? Now I have seen in practice people are using comoxiclav more. But I think we have to revert ourselves using these simple but amazing antibiotics for lower UTIs. Right. So what is a lower UTI? Dysuria, increased urinary urgency and frequency, lower abdominal pain. There can be suprapubic tenderness. So if you have that, you can have a clinical diagnosis of a lower UTI. What is the most common organism? E. coli and Klebsiella. So these are the most common organism which causes that. So if you have the clinical symptomatology showing a lower UTI, you can treat the patient with an appropriate antibiotics. And usual duration for an antibiotic for a lower UTI is 3 days. So 3 days is the usual treatment, and you will see a clinical improvement in 2 to 3 days time on the patient. And antibiotics shorten the duration of symptoms by 1 to 2 days. So sometimes even if you don't treat with antibiotics, the patient would improve because these are mild, very mild infections. So what are the choices of antibiotics that you can use? Nitrofurantoin And I personally use nitrofurantoin and co-trimoxazole. Because trimethoprim not freely available. Nitrofurantoin was not available sometime, but now I see that it's available. So you can give a 100 milligrams 12-hourly regime rather than giving the more cumbersome 6-hourly regime. And nitrofurantoin, mind you, is a very effective drug even for ESBL, extended spectrum beta lactamase producing E. coli and Klebsiella. You can use it even for that. So I think it is the best drug that you can use for a lower urinary tract infection. People are afraid of to use it, nitrofurantoin, but I feel if you have good education, treat it with an antiemetic, and you can use that for like 3 days, and then the patient would be feeling fine. And also other drug that I use is co-trimoxazole. I use this very frequently in my practice. We usually give for like 3 days. In elderly people, you have to give a half dose of this, very elderly, more than 70 years of age. And if the patient is having renal impairment, then co-trimoxazole is not preferred. A healthy person who does not have any comorbid renal problem, co-trimoxazole is a nice drug that you can use. You have to educate on few things. If they develop a rash, stop it and come back to you, right? Otherwise, all other thing is just to have good hydration, right? So a thing to brainstorm, is this the right choice? Fever and sore throat, I see that most of the people are on azithromycin for fever and sore throat. Is it the correct choice? Sore throat, I have seen people prescribing ciprofloxacin. Fever and cough, levofloxacin.
Cellulitis, comoxiclav and clindamycin. Lower UTI, comoxiclav. So these actually, ladies and gentlemen, are not the preferred first line, I would say. Let me explain why we should not be using it, why there is another option for this. Sorry, this is a busy slide. So talk about azithromycin. Azithromycin is a nice drug for like severe atypical infections caused by Legionella and severe infections caused by Salmonella. So I think it is a drug that we must reserve for a great cause rather than using for a sore throat. I think you can easily use amoxicillin and clarithromycin in these instances. I have seen people using ciprofloxacin, but I'm not sure how this came into the Sri Lankan picture in antibiotics. You know, people are having viral infections, and I have seen people giving ciprofloxacin. I don't have the understanding of why that has happened. Ciprofloxacin is a great drug for ESBL UTI and for resistant pneumonias. So we must reserve that for a greater cause rather than using it for like mild infections. So you can use amoxicillin for a sore throat instead of this. And ciprofloxacin is a drug in the group that ciprofloxacin, levofloxacin, all are in group that are second line for pulmonary tuberculosis. So if we use a lot of ciprofloxacin, we are inducing cross resistance for TB as well. And TB is a great threat in Sri Lanka. So in that case, we must not make our valuable drugs resistant for Mycobacterium tuberculosis. What about using levofloxacin in fever and cough? So levofloxacin is great for poorly responding pneumonias and hospital-acquired pneumonias. So I think we must use it for that cause. Instead, if there's a pneumonia, you can use doxycycline, you can use even amoxicillin, and you can use comoxiclav for that cause. Cellulitis, instead of comoxiclav and clindamycin, which can be used for like diabetic foot infections and severe cellulitis and also necrotizing fasciitis. So use it for that. And use flucloxacillin in your practice. Mind you, you can easily use flucloxacillin 500 milligrams 6-hourly for cellulitis. And also, if you think that the patient needs a higher dose, something like lymphedema, or if the patient is higher body weight, in that case, you can use 1 gram 6-hourly as well. And lower UTIs, instead of cefixime and comoxiclav, is great for pneumonias and pyelonephritis. So instead, use nitrofurantoin and co-trimoxazole. And nitrofurantoin, as I said before, has ESBL cover as well. So one thing about using cefixime, if you use it a lot, it will induce extended spectrum beta lactamase producers. So if somebody is using cefixime a lot on regular basis, that person is prone to develop ESBL infections. That is the main problem that I want to highlight in this presentation as well. So what not to use in the primary care and outpatient setting? Cefixime, try to limit the use of it. It is in the watch group of antibiotics. So we must use it because it's a third generation cephalosporin. It's like ceftriaxone or cefotaxime that we use for pneumonias in the hospital sector. So if we use cefixime in our outpatient setting, we are inducing resistance to a third generation cephalosporin, which is the first line for patients admitted with pneumonias to the hospital. We must limit that, or we must actually stop it. What I suggest is that. And levofloxacin, ciprofloxacin, moxifloxacin, we must not use this in our usual general practice, ladies and gentlemen. And azithromycin, we can use it for blood and mucus diarrhea, but not in other instances. And we must limit the use of comoxiclav as much as possible as well. I'll show you why. So what is unique about antibiotic that we have to understand? Otherwise, when we prescribe antibiotic, we have to always have this feeling, is this viral or bacteria? That's the first question that you have to ask. Because if you unnecessarily prescribe antibiotics, we are inducing AMR, antimicrobial resistance, which won't be a threat at the moment for that patient, but it will come back to us in another 5 or 10 years, and we will all be getting infections which are resistant to the common antibiotics that we use. And there are organisms which are resistant to meropenem as well, and those number of isolates are increasing with time. And mind you, ladies and gentlemen, we are working in hospitals. We are prone to acquire these bugs from the patients that we see on day-to-day basis. And if these resistant bugs increase prevalence in our community, we are at threat of having severe infections or dying because of antimicrobial resistance. So, ladies and gentlemen, don't we have a role in this venture of fighting against antimicrobial resistance? Because antibiotics have an individual impact and also a community impact, which we don't see in other drugs that we prescribe. So, ladies and gentlemen, every antibiotic prescription counts. So, think about that. So, this is some data from Karapiti Hospital, and you can see here, and this is the usage of antibiotics in the Karapiti Hospital that we see over six months' time. So, if you see here, ciprofloxacin has a very high use in the Karapiti Hospital, and I'm sure that is the same in other hospitals as well. And comoxiclav, cotrimoxazole, amoxicillin, doxycycline. So I'm happy that people have used a lot of amoxicillin, doxycycline, flucloxacillin, because these are in the access. The blue ones are in the access group antibiotic. These other ones are in the watch group of antibiotics. So we must definitely reduce the use of ciprofloxacin, levofloxacin, etc. Look at the cost. So out of 6 million rupees that we have spent in the outpatient setting, 2 million comes from comoxiclav prescriptions. So we not having a very stable economy and our health expenditure is so high, we have to think about ways to reduce the comoxiclav prescription because it's very expensive. And there are alternatives in certain other instances that we can use the alternative medication as well. So coming back to the basics of treating infections in the GP practice, 3 questions to ask. Is it viral and bacterial infection? So next day when you see a patient, try to develop your clinical acumen in differentiating viral and bacterial infection. That is one of the cornerstones of prescribing antibiotics, because if it is viral, you don't need to give an antibiotic because there is no benefit in that. So does it need antibiotic or not? So for that, it should be supported by your clinical judgment, because you will not be having any full blood count or CRP to deal with. And what is the appropriate antibiotic? You have to use access group of antibiotic. And we will be sending you that circular for your reference. So what is the misunderstandings? Amoxicillin does not work for sore throats now. It's a myth. So amoxicillin still works. It might be that you are treating a viral infection. So it will go on its natural course, irrespective whether you give an antibiotic or not. ciprofloxacin, levofloxacin, cefixime are better first-line choices of antibiotics. That's what people think. So it is not. We have to use these for a greater causes of severe infections in the hospital setting. Otherwise, we cannot be giving meropenem and vancomycin for all the people. We have to have oral antibiotics which are effective as step-down therapy or de-escalation therapy in the hospitals. And we must use it for that greater cause. Antibiotic resistance does not spread from one person to another. It is spreading from a person to person. It can spread from the hospital to the healthcare workers, from the hospital to the community. It can spread like a plague. And it is safe to give an antibiotic to prevent bacterial infection. We must not give any prophylactic antibiotics, and there is no place for that. So another thing to think about before winding up. So read about these three scenarios and think whether you would treat this infection separately. So first case is your own 15-year-old child develops a fever, runny nose and sore throat for 2 days. So you are sure that this is a viral infection. What would you do? So this is a clear-cut viral infection. I love my child. So ideally I should not give an antibiotic. It's a viral infection. You can, reassure the child and just wait. Lot of, salt water gargles, some steam inhalation and some good old kottamalli and stuff, and the person would recover, right? So we can do that. That's because that's our child, and naturally we expect that person to, listen to us. And another 25-year-old student visiting from United Kingdom having fever, runny nose and sore throat for 2 days. So you think of giving an antibiotic. Will you give that? I feel there could be some hesitancy because naturally that person will ask, I feel this is a viral infection and do you think the antibiotic will benefit me? And they would naturally question you and say, do I really need an antibiotic? So they will tell you because of that we are hesitant to prescribe an antibiotic for that person. We are geared to not to prescribe an antibiotic for those kind of people who are living in very developed countries who are not usually getting antibiotics. And the third case, at your practice, you see a 30-year-old having fever, runny nose and sore throat for 2 days. He requests antibiotic. So what would you do at that time? So sometimes in this instance also, ideal setting, you don't have to give an antibiotic. It's a viral infection. You have to give like symptomatic care. But I have seen in certain situations, these 3 scenarios does not have a single answer. So this is one point to think about, ladies and gentlemen. So in certain instances I have come across, when I'm talking to my colleagues, so they actually say, okay, we don't prescribe antibiotics for our children because we don't want AMR in our children. So we must safeguard them. Why not another person in the community? So, because if we give antibiotics for those people, we are inducing antibiotic resistance in the community. And it will backfire to our family and our community, to our region at some day. I'm sure it's not so far away. So, ideal setting, we must give the same answer in all these 3 scenarios. So, unity is strength. This is one thing that you have heard a lot, and the GMOA is having that. Ladies and gentlemen, when it comes to antimicrobial resistance as well, the unity will be strength. You cannot work alone. I cannot myself conquer antimicrobial resistance. As a region, as a district or a province or as a country, we should be working together, joining hands, working together as a team to combat antimicrobial resistance. Ladies and gentlemen, the bacteria are very intelligent. They know how to prepare, have induced genes which have resistant proteins for the antibiotics. So they are united to increase antimicrobial resistance. So isn't it the time that we have to be united to fight against the antimicrobial resistance? So Final word of thank you. I would like to thank the GMOA for giving me this wonderful opportunity to speak to all of you, and this platform. I congratulate GMOA for creating this platform, which is very important to provide medical education for all the doctors around the country, and I believe it's the most successful platform which is reaching all the corners of the country. And I'm happy to answer some questions. And if you want to have specific questions, you can take a photograph of this and save antibiotics for future at gmail.com. So you can either through the GMOA branch or else through this email, you can send the questions for me and I'm happy to answer that.
Thank you very much, Dr. Lakmal. So far, we have got a lot of responses saying that it was a very complete lecture, a brilliant lecture where they have you have helped them, our learned audience, to enlighten themselves with the practice of antibiotics. And I think as doctors, we should take the leadership in preventing antibacterial resistance in Sri Lanka, because it's a global issue and we should go with the global trends. And I think Dr. Lakmal, as a stakeholder of the antimicrobial resistant fighting task force in Sri Lanka, has given a wonderful insight into what we should do and how we have to use antibiotics effectively in our general practice, where most of our doctors are using antibiotics. So also I would like to ask you all to fill in the Google form that is a part of Dr. Lakmal's data collection, where they get an assessment from each and every general practitioner to see their knowledge on antimicrobial resistance, so that they can work in a national level to train all our doctors and bring them to a certain point where we use antibiotics rationally. So thank you very much, Dr. Lakmal, again for coming all the way to the GMOA office and sitting with us and enlightening our learned audience and disseminating the information all across Sri Lanka to all the general practitioners. And it's a national cause, and we thank you very much for coming here. And that winds off the GMO academic hour for this week. We hope to meet you with a very interesting topic in a fortnight's time. Thank you, and thank you very much. Have a good day.